Hey, welcome to my podcast. My name is Dr. Brendan McCarthy. I am the Chief Medical Officer of Protea Medical Center in Tempe, Arizona. Thank you so much for tuning in. We're at part 2 of our Estrone Series, and it has been interesting because the way that Evelyn and I do the filming for this is that we will film something on a Wednesday, and Evelyn is just awesome. I'm not just saying that because she's in the room with me. Um, you're probably going to edit that out. Evelyn will edit this and have it ready that night. And why that's, great, but also, not easy for her, but why it's great for me is that when it gets released Wednesday, Thursday, and Friday with reels. The episode goes out on Wednesday, but the Wednesday, Thursday, Friday go with the reels. I get your feedback right away. And then when I go to film the following Wednesday, I have your comments and your concerns already put into me. And this has been like this for every episode we've done so far in a series, which I think is a better part of a year now we've been doing it that way. So today's episode, I'm going to cover a little bit from the last episode because you brought up some very important points in our comment sections. So we're talking about estrone, and she's the forgotten estrogen. And last week we went into what is estrone, why is it important. I went into a little bit of biochemistry of it, just a little overview of it, and the concerns around it, and I talked about my frustrations and worries about its being missed in medical care. Today I'm going to get a little bit more deeper into the biochemistry of it. Today I'm going to go a little bit more into the specifics of it. I believe by circling back and delivering more information, being precise with my words, is helpful. To the degree it is, you can like this episode. To the degree you like what we do, please subscribe. And if you know someone that would benefit from what I'm doing, please, please, please share this with them. So let's get into the material at hand. Estrone, the overarching theme of today's episode is going to be that estrone is not the devil. It's not evil. And it's funny because I look back at some of my old reels and my old episodes, and I look back at a lot of my notes. And I actually have said estrone's the bad estrogen, and I need to stop that. I need to be better. There's no part of your body that's bad. There's no part of your body that's evil. These are just messages your body's sending us about a balance it's trying to restore. And I want you to see it through that lens. Estrone is a metabolic signal that your body is giving us when it's elevated. When it's out of range, it's a signal. And it is an opportunity for us to do something good. It's an opportunity for us to restore balance and harmony in you. So let's talk about estrone as a hormone in a very important context here. Estrone comes from your body fat. When you transition from pre and perimenopause into postmenopause, that is where estrogen comes from now. Aromatase, which is largely found in your adipose or fat cells, aromatase converts androstenedione into estrone. And the more body fat you have, the more aromatase you have, the more conversion androstenedione to estrone you have. The more estrone you generate and the more estrone you create in your body, estrone is going to be a little bit more pro-inflammatory. It's going to increase something called interleukin 6. It's also going to increase insulin resistance. It's going to impact your insulin sensitivity. It's going to promote more lipogenesis or more generating of body fat. So body fat makes estrone. Estrone promotes the inflammatory pathways to generate more fat, thereby making more estrone, making more fat. It is a wicked loop that we get caught in. And the important thing I want you to take away from that information is that immediately, it's very easy to say that estrone is a bad thing now. Estrogen's horrible. But if you look at it from our ancestors' perspective, it was the thing that helped them survive. It's just in modern day times, we don't need that. Estrone promotes the production of fat when it's already elevated, and it doesn't do that in a vacuum. You have to have other factors at play in your lifestyle for estrone to be so pro lipogenesis. You already have to be eating a refined diet. You have to have more inflammation in your body. So this doesn't just happen in a vacuum. Like all of a sudden my body fat's going to make estrone, it's going to make more body fat. You're not stuck in that loop, okay, by itself. There are things you do with your lifestyle that promote the loop even more so. And that's the thing. I don't want you to feel trapped by what I'm saying here. I want you to feel empowered because that's the goal of this. Another impact of estrone is that it inhibits insulin receptor phosphorylation. When that occurs, your serum glucose levels are going to go a little bit higher. As serum glucose levels go a little bit higher because your insulin receptors are not working very well, your serum glucose starts to go higher. That elevations in glucose, you're going to be increasing your levels of insulin to match that glucose. So the higher levels of insulin coming from higher levels of glucose is going to feed the same pathway forward of hyperinsulinemia. And the higher your insulin levels are, the more your body wants to store fat. When estrone is elevated and it's more pro-inflammatory, it stimulates this nuclear factor kappa beta pathway. So elevated levels of estrone are going to stimulate something called nuclear factor kappa beta in your body. Nuclear factor kappa beta is pro-inflammatory. Nuclear factor kappa beta is going to increase something called interleukin 6, and it's going to increase something called C-reactive protein. Why do you need to know this? That's a lot. This is important for this reason, not because I know some of you are doctors watching this, but for you as the patient-wise, it's important. Because this is how we put our hands around this. You are supposed to have estrone. Estrone's an important part of your biology. How on earth do I know it's pathological, though? Running a lab with a woman with estrone and understanding her estrone is just the starting point. You're supposed to have estrone. The question is estrone occurring in a pro-inflammatory diet, a pro-inflammatory lifestyle? If it is, then that nuclear factor kappa beta pathway is going to be cranked up. Now, we can't directly test that out. There's no commercial testing for nuclear factor kappa beta, but there is for interleukin 6 and C-reactive protein. There is for insulin. So when the woman comes into clinic and I'm looking at that estrone, I'm not just going to look at her estrone. I'm going to look at her C-reactive protein. I'm going to pull interleukin 6 maybe. I'm definitely going to look at her insulin. I want to understand her estrone in context of her body and her health. Why do I want to know more about that estrone? Is it only because I'm talking about body fat? So far, that's all I've been talking about. So you can easily say, McCarthy, is it really anything else other than weight? I mean, is that all you're talking about with this? No. Remember, we talked about inflammation with this. It's important to stay in context with that because estrone, it does a lot of other things as well other than weight gain. Estrone is strongly associated with breast cancer and breast pathology. That is true. When your body is in a pro-inflammatory state, you're not methylating. Liver detox pathways are not working very well. Macronutrition is not good. Low antioxidant status. In that type of environment, when you have normal levels of estrone, it will be preferentially converted to the wrong kind of downstream metabolite. See, this thing about estrone, as I mentioned, in and of itself is pro-inflammatory. We should know this. And it's pro-body fat. We should know this, treat this. This is important. But the downstream metabolite of estrone, what else does it do in the body? How does it get out of the body? The next step of its elimination is this liver detox pathway. And if estrone is in an environment in your body that's not very healthy, as I mentioned before, poor antioxidant status, pro-inflammatory diet, not methylating. This is the environment where estrone wants to push down to the 16-hydroxyestrone pathway, which is more pro-pathological for breast tissue, pro-proliferative. If you were to have a woman who has estrone levels, you have two women, same level of estrone, one woman more pro-inflammatory, in the environment, in her body, she can move towards that 16-hydroxy pathway. The other woman, same level of estrone, a little bit better with her health. She's taking better care for methylation. She's eating well. She put micronutrients in her body. She's doing good exercise, taking care of herself, adequate fiber in her diet, etc., which are things we'll go over more in this episode and next. That woman doesn't have the same risks. She's not going to be converting to 16-hydroxy as well. So it's not always treating just estrone, and you're supposed to have it, but it's more treating the environment where we find estrone and understanding the whole of the woman in front of us. This is where medicine is an art. This is not paint by numbers. This is not an algorithm. This is a human being, and there are multiple systems at play. It sounds complicated. And I've said this before, I want to really circle back to this very important fact. Everything I'm saying sounds complicated. But so is the same idea of taking directions and driving to your place of work or driving home, knowing that certain roads you need to take when there's high traffic. You know that there's certain ways you can go on the way home. You can stop by this one place you want to go and get your groceries. There are so many steps involved with driving home. If you ever want to do that, sit down and write them all out, and you learn them, and you're able to do it. There's things you do every day that takes multiple steps, very complicated things we do as human beings. I want you to know this because this impacts your life. This echoes forward in your life. This is a very important topic we're discussing. And 20 years, practicing a long time. There's so little out there explaining estrone. Trying to search for it, very little. It's very difficult to tease out research on estrone because they don't do a lot of research on women. And then doctors applying this in clinic, a lot of doctors are paid on their throughput, the amount of patients go in and out of that clinic. They're not going to sit down and dial into this with you. So me sitting in this space with you is making sure I do my best to educate you so that you're empowered as a woman to go to your doctor and seek true health, good health care, true health care. That's why I really want to teach this to you. I'm trying not to make it mystical because it sure as heck isn't. And I'm trying my best to be really clear with it because you deserve to know this and understand it. The other part I wanted to bring in today regarding estrone and where it comes from, for years in practice, and if any of my patients watch these videos, and some of them do, it's funny sitting in the room with your patient, they come in, I was watching your reel, and it's like, I don't know how to explain what it's like to do these videos, because right now, to me, it's just me and Evelyn in a room together, hanging out, and I'm just talking, and I'm sharing something I believe in and I understand. And then having people actually watch this online is incredibly humbling. Incredibly humbling, please know that. But still, if my patients watch this, they'll be like, yep, he's done this before. He said this is true. He does that. When I see estrone elevated, one of the very first things I think about is endocrine disrupting compounds found in the environment around you. BPAs, phthalates, these compounds, microplastics, PAAs, all these compounds, they're all endocrine disrupting to a degree. And when I run an estrone on my patients, this is not a perfect one I'm about to describe, but if I see elevation in estrone, I often am able to infer from that microplastic exposure. Because I'll have patients come in, they have elevated estrone, and I'll kind of go through their lifestyle and their diet diary and say they're doing like K-cups, the coffee that they put in the plastic little things and you put the hot water through it. That plastic is going to leach into your body. And when your body has to process the BPAs and phthalates out of your body, it's going to preferentially focus on that, and it leaves estrone behind. Estrone is not going to go down. Your estrone stays elevated because your body's more focused on detoxifying those other compounds. Furthermore, those other compounds partially bind to estrogen alpha receptors, which is more proliferative, not very good. So when I see a patient with elevated estrone, I also need to sit down and go over their environmental exposure and their lifestyle. How much plastic did they use? Because this is a true factor. This is a true concern. Further, and this is one that grabbed a lot of women on my last reel, and this is why I'm kind of drilling down on it, the last episode and the reel from that episode. I want to drill down into this and be really precise with you again. Oral estrogen, there's no safe amount of oral estrogen that we know, given its conversion to estrone. When you eat estradiol as a pill, it's going to have first pass through your liver. Liver's going to adjust it and change it and turn it, hyperconvert to estrone. This is one of the big problems of taking oral contraceptives. This is one of the big problems with taking any type of oral hormone replacement therapy that's estrogen based. Now you can do oral, progesterone, perfect. Oral testosterone and oral estrogen are not good. That's going to lead you to having a higher risk for clotting due to stimulation of thrombin. And that elevated estrone from your oral contraceptive actually makes you feel worse. So when you have a woman presented to clinic and, her estradiol is like, say, 28 picograms per mil, and you have an estrone somewhere like 130, and, FSH, say her FSH, she's menopausal, let's say that's like a 50 or 60 or something, her insulin, say her fasting is like 16 or 17. That's not estrogen deficiency in front of you right there. Bear with me on a minute. That's estrone dominance in that woman. Giving that woman oral estrogen, because all you did was run the estradiol, actually will make her much worse. Much, much worse. Much worse. This is why women who take oral estrogen as a hormone replacement therapy have such high fail rates, why they don't feel good. Because when you have a woman with that profile of 28 estradiol, 130, 140, whatever it was for estrone, giving her more oral estrogen or estradiol, that's going to cause her estrone to skyrocket. As I mentioned, estrone, what is it going to do when it's high? Insulin levels spike, inflammation goes high. It does also affect brain chemistry and mood, water retention, weight gain around her abdomen. And she doesn't know why. Breast pain, and she doesn't know why. This is estrone at play. This is why this lab is so important. How many of you, I'm being really honest right now asking this, how many of you have gone to your primary care with menopausal symptoms and they ran maybe an FSH, maybe, or as, some doctors, these doctors will shout out on their Instagram pages, I don't need labs. I listen to the woman in front of me. I just treat her because she tells me she's not feeling right. That is just bullshit. Excuse my language. That's a horrible way to see the woman in front of you. That is not what we do as doctors. That is absolutely irresponsible. Because the woman that comes in the clinic to see you has that elevated estrone. What are you doing? You're playing odds with her. The odds are 80% of the people will respond with your estradiol the way you're doing it there, just free basing it, just handing it out to anybody, raw dog, no labs. 80% of the time, you're gonna be good. But the 20% of the time, they're not good. And that 20% of the time, that's too high. That's too high a percent. We do our work, we cross our T's, we dot our I's, we do our labs. You deserve no less. And the labs don't have to be boutique $1 million labs. We use your insurance. If insurance doesn't cover it, we try and get better cash labs for you. I've talked to you before. I know, hold on. The companies like Life Extension have really good discount programs. It's a website. You grab labs there. There's ways of getting these tests done at reasonable prices. And you're doing these tests twice a year. And yes, it could be a lot of money. Yes, you're right. It could be $200, $300 every 6 months for your labs. I'm not insensitive to this, not even a little, but it's your life. I don't want to do it without that. No doctor, self-respecting physician will prescribe hormones without lab work. I want to make one caveat to that. There's the old saying that Maya Angelou said, do the best you can until you know better. And when you know better, do better. So if there's a care provider out there that has been just writing hormones without running labs, well, it's on us to learn. And once we learn is then now to act upon that learning. So how do I modulate this stuff? What do I do? Where's my brain around here? Where's some of my therapies I do? I'm going to go over a little bit today, but next time we're going to go way more in depth on therapies that work and management strategies around this. But I just want you to know the first thing, diindolylmethane. Diindolylmethane is derived from cruciferous vegetables. DIM is another name for it that's popular out there. Diindolylmethane really plays a role in modulating that conversion of estrone to 2-hydroxyestrone, and it modulates it away from the 16-hydroxyestrone. So you're going to be actually moving it more towards the healthier metabolite, less towards the more breast proliferative or pathological metabolite. So diindolylmethane, critical, big thing in the practice. I'm a fan of it, but I also advocate my patients to eat broccoli, eat cruciferous vegetables. Get that in your diet. I prefer food. Supplement as needed. Calcium D-glucarate, that was a popular one. I know Dr. Warren Brittany, the doc I work with, she's a big fan of that one. And that does play a role in the detox pathways as well. Cal D-gluc is a good thing to throw in the equation. Omega-3 fatty acids and resistance training, those guys play a role in lowering nuclear factor kappa beta, as I mentioned earlier. That's that pro-inflammatory pathway that estrone likes to push, that has a higher risk factor for systemic inflammation, weight gain, sure, but also breast pathology. Nuclear factor kappa beta, we want to turn that down. So omega-3 fatty acids, resistance training, those things work. They're helpful. Progesterone, and that's the biggest thing. I always want to make sure I'm using progesterone in this equation with women. I need to balance my repair. I need to find balance in those women. Nothing that I just said was a fad. Nothing I said in there was weird. Everything I just said, biochemistry, basic stuff, nothing fancy. It just sounds that way because I'm recommending supplements. But these are the things that I'm going to use to modulate the way your body metabolizes estrogen. We do labs to verify our work. We do labs to be accountable to you. The thing is, you can't get rid of estrone, but you can guide where it goes in your body. We never want to fully get rid of estrone because we can't. And we should never have that as our goal. Our goal should always be to guide it where it goes and understand why it's out of balance and treat the cause of that imbalance. That's where we get our best work done. And it's not that hard to do. We ask why it's elevated. We see what's the body fat level look like? What's hepatic clearance look like? What does environmental toxin look like? We look at all these things. What is their insulin levels, their fasting insulin look like? We ask these questions to understand why estrone is elevated, what's contributing to it, and what it is contributing to itself. Every case I see is unique. When a woman contacts and says, I have high estrone, what do I do? I don't want to be coy and silly, and I'm not trying to be too cute by half by saying it depends on why it's elevated. But that's the truth of it. It's an opportunity when we see estrone elevated to understand why it might be out of balance, which area, what's drawing out of place. Maybe it's more than one, maybe it's all of these things. But we don't know until we spend time with her to understand her. It's bad medicine for someone to say I'm going to do this really bad, right? I'm going to say estrone's not good for you. These are reasons why you should take Brenda McCarthy's DIM, which I'll never sell. I will never do this to you. I'll never pitch you products like that. But that's irresponsible because that's not understanding the whole of you and really getting a full understanding of why it's elevated and what the environment within you is. Like DIM is not going to treat insulin. DIM's not going to go after that. DIM's not going to really help with environmental toxins. If you want to become better from, endocrine disrupting compounds, you can help your body detox them. But honestly, you need to stop being exposed to them and control for exposure. DIM doesn't do that. DIM's not enough. You need more than that. You need the removal of that exposure. Another thing I wanted to circle back into and be very clear with you on is the trauma component and the emotional state that women go through when estrone um, becomes dominant like this and sometimes out of control. It is not a vanity, what I'm about to bring up here. This is not a vanity. But body changes affect your sense of identity and sense of self. Weight gain and the abdominal weight gain, for many women, they feel invisible. And that is a valid concern. And it's not a vanity. There's a sense of loss that happens with women as they transition through this time. It can be so incredibly unsettling. And then when their body starts reacting differently and they don't feel like they have control over it like they once did with lifestyle and self-care regimens they once did, this is a very vulnerable place to be in. So when we sit down with these women, we have to be heart-centered. We have to be aware of the sensitivity of the woman in front of us, the vulnerability that she's in. Because think about this. I'm talking about body changes, right? Weight changes. These things are serious and concerning. But I'm also touching on the idea of breast cancer in the same breath. Same breath. And it's a woman in the room with me, a human being, vulnerable human being. This is when being a care provider, this is when you really provide care. So sitting in the room with them, you have to be sensitive and thoughtful and caring. And I'm a work in progress. I'm not perfect. No one's perfect in this world. I know this to be true. I still work every day at this because it's worth it. When a woman's body changes, when the hormonal landscape changes, she just doesn't just lose her hormones. She loses a part of who she once was. It's so sensitive and tender that morning. And being a care provider, again, this is that moment where you need to shine as a care provider. So the Protea Way framework, the framework of how I approach these patients, I do 5 domains of terrain medicine. I put this in terroir medicine I used to work in the wine industry years ago. I lived in Australia a long time ago, and I worked at vineyards in West Australia, just outside Perth and Margaret River. And I loved that time of my life. I was a kid. Not a kid, I was an adult still, but it's just a long time ago. But terroir, so I'll throw those terms out every once in a while. But it's the thing, it's the terrain of the woman in front of me. It's the environment that she's in. I see her um, through this lens of something that's beautiful and growing. So the 5 domains that we go into, this was, endocrine stability. I would look for that estradiol and estrone ratio. And I look for her progesterone, make sure that's in balance. We do metabolic balance. We start to look at what the insulin sensitivity is for the patient. We look at triglycerides, HDL cholesterol, ratio those out. We start to work at that with the patient. What other labs that we do? Inflammatory tone, C-reactive protein, interleukin 6. C-reactive protein is a nice, well-priced lab. Interleukin 6 is a little bit pricier. You can get it through insurance. It's worth doing. Sometimes it's not easy to pull. Still, interleukin 6 and ferritin. Ferritin's another good inflammatory marker to do to see what the environment of inflammation is in the woman in front of us. Detox pathway, we want to understand methylation. Homocysteine is a good way of doing that. Mean corpuscular volume is part of a CBC panel. That could be helpful to understand as well. Her methylation, because it's inferred through that, that you have enough B12 and folate methylated in order to make DNA. So that's what that MCV can be elevated from. Now, this is not perfect, but it's a good one. And then further, we look for glucuronidation, sulfation, gut health. And then finally, we really look at the environmental exposure the patient has to plastics, BPA phthalates, things like this nature. Because when we step in the room with that woman, we want to think about all these different areas that could have caused estrone to be elevated. and different areas where I can step in and be helpful. I'm going to leave with just a few of the quick little therapies that I do that I find to be very helpful for estrone. Just I had three ones I'm going to throw in here real easy. I want you to know I'm very much anti UPFs or ultra processed foods. Anything you don't make yourself, you can't replicate in a kitchen. Anything that has recipes that don't look normal, things that you can't make yourself, ingredients that are not commonly found in the supermarket, in and of themselves, those are ultra processed foods. And these foods have been manipulated to increase the glycemic index and to get, a certain benefit to the person making it. It means you buy more of it. And these foods tend to make us more insulin resistant. These foods tend to bump up our blood sugar. These are not good for us. So ultra processed foods are things that I really sit down with my patients and try and understand their consumption rate, because that's a way that I'm going to help drive down that insulin. That's one of the things I do with my patients: to understand their diet, try and get them off of ultra processed foods, promote more of a whole food diet, well balanced diet, high fiber. What else? Crucifers, alliums, citrus peel. These things help. Allium, garlic, citrus peel is citrus peel. And crucifers could be the cruciferous vegetables. That's, broccoli, cabbage, Brussels sprouts. These things will all help that detox pathway, and that'll help reduce estrone through your liver detox. Wild fish, micronutrients, vitamin B6, magnesium, selenium, and zinc. These all things are antioxidants and anti-inflammatories to reduce that nuclear factor kappa beta pathway and reduce as much inflammation as possible. These are three good tools we have when we go in the room with our patients. I hope this is helping. I hope this is helping. I want to be good at this because of the benefit that I feel it will give. No other reason. No other reason. I want to do a good job because I want to be helpful. So to the degree I'm doing that, we're good. The degree you can give me feedback, I'll take it. I'll take it. I'm good with feedback. I'm good with feedback. I look forward to seeing your comments on the reels, on the episode on YouTube. I look forward to hearing back from you. The next episode, I'm going to go into detail about testing, the testing we do around it, and become more precise with what we prescribe around this to help treat these women. I look forward to seeing you at the next episode.